Hello everyone, myself Rakesh.K.S, second year MBBS student from CRIMS Corp. Today I am going to discuss about gestational trophoblastic diseases. We will discuss gestational trophoblastic diseases under these conditions: definition, classification, and pathology of each gestational trophoblastic diseases. We will discuss pathology under these headings: etiology, pathogenesis, morphology, clinical features, and diagnosis of each. First, we understand what is gestational trophoblastic diseases. A spectrum of interrelated tumors and tumor-like conditions originating from the placental trophoblast. It means a tumor or tumor-like conditions which are originating from the placental trophoblast after a fertilization, or the gestational trophoblastic diseases. Further, we will understand the classification of gestational trophoblastic diseases. It is classified into hiated form mole and gestational trophoblastic neoplasia. Hiated form mole is the benign or malignant condition of this disease, and gestational trophoblastic neoplasia is the malignant condition of this disease. Further, hiated form mole is classified into complete hiated form mole, partial hiated form mole, and gestational trophoblastic neoplasia is further classified into invasive mole, choriocarcinoma, and placental site trophoblastic tumor. Next, we will discuss each type of the gestational trophoblastic disease. First, we will discuss hiated form mole under definition and pathology. A hiated form mole is a benign tumor of placental trophoblast characterized by hydropic swelling of chorionic villi and trophoblastic proliferation. It means it is the benign tumor which originates from the placental trophoblast cells which have hydropic swelling of chorionic villi, and hiated form mole is further classified into complete hiated form mole and partial hiated form mole. Let us discuss the classification of hiated form mole. Firstly, complete hiated form mole. As it is a benign condition, we will discuss risk factor. Risk factor for this condition is maternal age less than 20 years and greater than 40 years. It means if a female conceives a pregnancy under less than 20 years and above 40 years, has high risk of having this complete hiated form mole. And a female having previous molar pregnancy or also have high risk, and nutrition deficiencies like vitamin A and folate are also have the high risk for this complete hiated form mole. And further, etiology. A complete hiated form mole results as an empty ovum that has lost its maternal chromosome is fertilized with the one sperm duplicating its chromosome or two sperm fertilizing the empty ovum. Before discussing about the etiology, we will first discuss about or understand about the empty ovum. Empty ovum means it is the one ovum which has lost its maternal chromosomes, means it has no chromosomal contents. As this ovum is fertilized by one sperm which duplicates on fertilization or two sperms fertilizing the empty ovum, it results in the complete hiated form mole. The resulting karyotyping is 46XY. As the only parental chromosomes are present, there is only XX is the karyotyping. So 46XX is the resulting karyotyping. Then moving on to pathogenesis. An abnormal fertilization of the empty ovum means an empty ovum is fertilized by the single sperm or double sperm, which having the karyotyping 46XX. As this ovum lacks the maternal content, the entire genome becomes parental, means androgenetics. This androgenetics expresses excessive parental genes, which leads to marked trophoblastic proliferation and diffuse hydropic swelling of chorionic villi. Then come to the morphology. Morphology of complete hiated form mole. First, let us discuss the gross. In gross, the uterine cavity is filled with the delicate, fragile, and grape-like vesicles. You can see the diagram there is a grape-like vesicles which is present in the uterine cavity, and here there is no fetal parts are present because there is no material content. The fetus formation is not well developed. Then come to the microscopy. In microscopy, there is a diffuse hydropic swelling of villi and decreased vascularity of villus stroma, circumficial trophoblastic proliferation, and absence of fetal blood vessels. As the definition only says, the iatid-form mole is the diffuse hydropic swelling of villi. Means the villi are largely enlarged and that it has hydropic contents. And due to the enlargement of villi, the decreased vascularity of villus stroma, and there is a proliferation of the trophoblastic cells. And as there is no maternal content, there will be no fetus, and therefore there is absence of fetal blood vessels. Next, then comes to the partial iatid-form mole, and this is the second type. And the risk factor for partial iatid-form mole is same as complete iatid-form, but it has often presents as missed or incomplete abortions. Means in case of missed or incomplete abortions, these partial iatid-form mole have the high chance of occurrence. And then come to the etiology. In etiology, a partial mole is caused by abnormal fertilization of an ovum with 2 sperms or by 1 sperm with duplicating its chromosome. The etiology is same as complete iatid-form mole, but there it has only empty ovum is fertilized by the sperms, but here the mature ovum is fertilized by 2 sperm or 1 sperm that duplicates on fertilization. Here the karyotyping is 69XXY or 69XXX, as the karyotyping is triploid. Pathogenesis of partial iatid-form mole. Normal ovum is fertilized by the 2 sperms, giving rise to triploid zygote formed. In this, there is an excessive parental genetic material, which leads to the abnormal placental development, which giving rise to the focal trophoblastic proliferation and hydropic swelling of some chorionic villi. This will lead to formation of enlarged villi with trophoblastic inclusions, leading to the partial mole development. Further, moving on to the morphology. In morphology, firstly, gross. In gross, there is both normal and hydropic villi are present, and the fetal parts or membranes may be present because here the both parental and maternal chromosomes are present, giving rise to the fetal development. And the uterine is enlarged and is less marked than the complete mole. Then comes to the microscopy. In microscopy, there is both normal and enlarged hydropic villi, and there is a trophoblastic proliferation and fetal tissues are present. As there is a fetus formation is possible, the fetal tissues may be present. As fetus is present, there is a presence of fetal blood vessels or fetal tissues is common. Then coming to the clinical features of iatid-form mole. And some clinical features are both common to the complete and partial mole. And those common features are vaginal bleeding in the early pregnancies, enlarged uterus, passage of grape-like vesicles, absence of fetal heart sounds, often occurs in the complete mole, and anemia. These are the common features of the iatid-form mole. And the unique features of complete iatid-form moles are there is no fetus or no amniotic sac, as there is no proper fertilization, and it has very high beta HCG levels, and it is highly potential to form a malignant conditions like invasive mole. The unique features in a partial iatid-form mole are presence of malformed tissue or fetal tissues, as there is a tissue of a fetus is possibly formed, and there is less marked beta HCG level than in complete mole, and it has a less risk of forming to malignancies than the complete mole. Diagnosis of iotide form mole. Serum beta HCG is markedly elevated, as mainly in complete mole it is higher than partial mole. And then the next diagnostic criteria is ultrasound. In ultrasound, the complete mole appears like a snowstorm or cluster of grape appearance, and there is no fetus formation. In partial mole, there is a fetus formation or fetal parts may be seen, and the cluster of grape appearance also seen in partial mole. And in histopathological investigations, it is a confirmatory diagnosis for evacuation. And in karyotyping or genetic testing, it helps in differentiating partial or complete mole. As the both karyotyping are different, it helps in the differentiating between these two moles. As you can see the grape-like structures in the ultrasound of complete or incomplete iotide form mole. This is the ultrasound of complete mole. Let us now discuss the difference between the complete and partial iotide form mole. The incidence of complete iotide form mole is 1 to 3 is to 1000. In the partial iotide form mole is 3 is to 1000, means the partial iotide form mole has the higher chance of occurring. And in karyotyping, the complete iotide form mole has diploid karyotype, partial as triploid karyotype. The pathological differences are fetus and amniosac are absent in complete, it is present in partial. And further, the trophoblastic proliferation and atypia is markedly seen in complete iotide form mole rather than partial iotide form mole. And in clinical presentation, the uterine size is larger for dates, means it has more enlarged uterus in complete, and in partial smaller or corresponding to dates. And the beta HCG level is markedly increased in complete iotide form mole, and it is less markedly increased in partial iotide form mole than the complete iotide form mole. And the diagnosis for the complete iotide form is molar gestation, means previously molar gestation, and for partial iotide form mole is mixed abortions. And the progression to choriocarcinoma or malignancy is 3% in complete iotide form mole and 0.1% in partial iotide form, as it is less risk for the progression to choriocarcinoma. Then till now we have discussed about the iotide form mole. Now we will move on to the malignant condition of the gestational trophoblastic disease, that is gestational trophoblastic neoplasia. In gestational trophoblastic neoplasia, we have three conditions: invasive mole, choriocarcinoma, and PSTT. Now let us discuss invasive mole. An invasive mole is a gestational trophoblastic neoplasia characterized by penetration of molar villi into the myometrium of uterine vessels. It usually develops after a complete iotide mole. Means invasive mole is developed from the complete iotide form mole. As in complete iotide form mole, there is no invasion of the chorionic villi to the myometrium. But as further it complicates, the molar villi are invaded into the myometrium or uterine vessels, leading to the invasive mole or malignant conditions. Risk factors for invasive mole are previous iotide form mole, as it is developed from the complete iotide form mole, or extensive extreme of reproductive age less than 20 years and greater than 40 years, history of prior molar pregnancy, and it is more common in Asian countries. These are the risk factors for the invasive mole. Then moving on to the pathogenesis, most cases arises from the complete iotide form mole. As we have discussed later, the chorionic villi are invaded to the myometrium, leading to the invasive mole. Persistent proliferation of trophoblastic tissues occur after evacuation of mole. And if the previously occurred molar pregnancies, the mole is evacuated, but there is a presence of some tissues leading to the trophoblastic tissue proliferation, which forms invasive mole. And hydropic chorionic villi invades deeply into the myometrium and uterine blood vessels. And as this is a malignant condition, it leads to the metastasis to the other sites like lungs, liver, etc. Majorly lungs. Then moving on to the morphology. In gross, we say enlarged bulky uterus and hemorrhagic and necrosis are present, and cystic grape-like vesicles invades uterine walls. As the uterus is enlarged and it is a malignant condition, there is a hemorrhage and necrosis are present, which it is due to the lack of blood supply, and there is a grape-like vesicles invade to the uterine walls. In complete or partial idet, there is no invasion of the chorionic villi to the uterine wall, but here there is a invasion of the chorionic villi to the uterine wall, leading to the grape-like vesicles invading uterine wall. In microscopy, it is similar to the benign condition of idet-form mole. Presence of hydropic chorionic villi, proliferative trophoblast, and invasion into myometrium and vascular changes is the main difference between the complete and invasive. Hemorrhagic and the necrotic areas are common as it is a malignant condition. In this picture, we can see the invasion of the villi into the myometrium, and there is a trophoblastic hyperplasia, and the myometrium is invaded by the villus. Now we will discuss about the clinical features of invasive mole. Invasive mole is presented by the persistent irregular vaginal bleeding after evacuation of mole. Means if the female having the molar pregnancy, after evacuation of mole, there is a persistent vaginal bleeding, which give us the hint of invasive mole. And enlarged uterus, pelvic pain, passage of vesicles, and features of metastasis. As it is a metastatic or malignant condition, there is a chance of spread to the other organs like lungs, it spread to the lungs, brain, and etc. And in diagnosis, there is a persistent elevation of the beta HCG after the molar evacuation. After the surgery of molar pregnancy, there is a persistent increase of beta HCG, give the hints to the invasive mole. And in ultrasonography, there is a mass invading the myometrium is seen. And for a metastatic condition, the chest X-ray and MRI can be done to see whether the metastasis has occurred or not. Now, let us move on to the other type of the malignancies. It is choriocarcinoma. Choriocarcinoma is a highly malignant tumor derived from trophoblastic cells that normally from the placenta. It is characterized by early blood-borne spread and high level of beta HCG. Means as it is a malignant condition, it is has a chances of spread from the other organs through blood to the placenta, and it is originated from the trophoblastic cells. It may occur after a normal pregnancy, following abortion or ectopic pregnancy, and most commonly after a idet-form mole. As this is also most common in females having complete or incomplete idet-form mole. Risk factors for choriocarcinoma are previous idet-form mole, extreme of maternal age less than 20 and greater than 40, prior history of gestational trophoblastic disease, and abnormal fertilization event. And pathogenesis. Choriocarcinoma is developed from the trophoblastic epithelial and consists of malignant proliferation of cytotrophoblasts and syncytial trophoblasts, as these two are the layers of villi. And it is usually spread to ovary through hematogenous spread, as this malignancy is spread through the hematogenous or blood route. Morphology. First, the tumor appear as hemorrhagic, soft and fleshy mass. Sometimes the tumor may be small, often like a blood clot in the uterus. Microscopically, as an absence of identificial villi, as there is a proliferation of syncytio and cytotrophoblasts, the villi are not identified properly, and invariable presence of hemorrhagic necrosis, invasion of the underlying myometrium and structures, blood vessels, and lymphatics. These are the microscopic findings. This is the microscopical findings in which we can see the invasion of the malignant cells to the myometrium. Important features of choriocarcinoma are: there is no formation of chorionic villi, as there is a proliferation of syncytial and trophoblast, and cytotrophoblast. Tumor invades uterine wall aggressively, produce very high level of beta HCG. As it is a malignant condition, there is a chance of metastasis of tumor cells. It spread to other site early by heterogeneous spread occurring especially to lungs, brains, liver, and etc. Clinical features are irregular vaginal bleeding after pregnancy, enlarged uterus, amenorrhea, passage of blood clots. And it is a malignant condition. The associated symptoms, prognosis of this malignancy is it is highly malignant but very sensitive to chemotherapy. It responds to the chemotherapy given. In this picture, we can see the different types of gestational trophoblastic malignancies. The first one is complete hydrated form mole, in which there is a grape-like vesicles, no fetus. And in second, there is a partial hydrated form mole, in which the grape-like vesicles are also seen, and there is a presence of fetus. And third one is also same. And in fourth one, there is a invasion of the grape-like vesicles into the myometrium. And in fifth one, there is a choriocarcinoma invading throughout the myometrium wall, and there is a metastasis to the lungs. And in fifth one is the placental site trophoblastic tumor. Thank you.